First of all, I welcome our President, Dr. Senguttuvan sir, for joining this program. And I welcome Dr. Abullashan sir, immediate past President for the program, and Dr. S.S. Sugumar sir, our advisor for the Blood and Organ Donation Committee, and Dr. B. Sridhar, the State President-elect 2025, and our Secretary of IMA Tamilnadu, Dr. S. and our Treasurer, Dr. S. Gauri Shankar sir. And this month, we are going to conduct the program of Blood and Organ Donation Committee along with the Erode IMA. I welcome you all for the program. At the same time, I also welcome the speakers of the day, Dr. S. Meghala, Dr. Saraswati Vijay Kumar, Dr. Prabhu Murugesan, Dr. Kanimuli, Dr. Jayandan, Dr. B. Gayatri, and Dr. Vinod. Every month we are having this the Blood and Organ Donation Committee meeting, and some of the slides we are repeating it because some of the people are attending for the first time. That's why we are repeating some of the slides. This is the Organ Donation Committee. This time we are having a bigger committee. And this is the emblem which was used last year. And this is the new emblem because the Blood and Organ Donation Committee is together. So we have created where it is showing the organ donation on one side and the blood donation on the other side. So this is the old and the new emblem. So every month we are having the last Tuesday, we are having this meeting. I request all the branch presidents, secretaries and finance secretaries to spread the message to all the members so that all of the people may be knowing very well. And in month of February, it was by Trichy, and in March, it was by Avinasi Tech City. And in April, we are conducting with Erode, and every month we are planning to have a different IMA branches program. And this was the January, this is February, and this is the March meeting, and this is the April meeting. The blood donation activities which were done in the month of March is by Satyamangalam. IMA Dhanmantri Blood Center Component Separation Unit was inaugurated by our President Dr. Senguttuvan sir in the presence of the State Secretary Karthik Prabhu sir and Finance Secretary Dr. Gauri Shankar sir with the Rotary District Governor Suresh Babu and other IMA officials. On 15/3/2025, blood donation camp was conducted in the Banariam and Engineering College. 130 units of blood was collected. And blood donation activity from the Coimbatore branch was number of units connected were 632, and number of issued to the hospital 365. Number of blood donation camps they have conducted were 8. And they have conducted in Dr. NGP Arts and Science College 285 units collected. In Larsen and Tabro 24 units. Dr. Fixita Champions Club it is 10 units. And Nehru College of Physiotherapy 28 units. And Tata Consultancy KPR 66 units. Royal and LN College of Nursing 80 units. TVS Personal Mobility Solution 16 units. And Maran School Sullivan Street 3 units. And PPG College of Engineering 90 units. Total number of units collected 602. And another one is the Erode branch, which is they are also doing a nice activity. 476 units are collected. They have conducted around 8 camps. The one is at Periyar Mandram Auditorium, 20 units, and KSR Arts and Science College, Tiruchengodu, 40 units, Kongu Engineering College, Perundurai, 70, Nagamalai, Tirumana Mandapam, Archalur, 35 units, and Erode Sengundar Engineering College, 175 units, and CD Rotary Hall, 67 units, and City Union Campus, 53 units, and RC Church, 16 units, 476 units are blood collected. So regarding this eye donation, we wanted to create awareness through our ophthalmologists so that we will have a lot of eye in access. We conducted a plan to start IMA Blood Bank or IMA Retrieval Center. That is the main aim of doing it. And Erode people I think they are having a more of a retrieval activities more, and we next month we will have a separate meeting regarding the eye retrieval itself separately. And the organ donation meeting, I request all the branch people to conduct, the president and secretaries to conduct meetings in the branches, in the colleges and the schools. Now is that schools and colleges are holidays, and now you try to conduct the camps in the Rotary clubs and in Lions Club like that. And this is the handout which already been circulated in the State Council meeting. It was printed by the author IMA office bearers. Our president being the author branch, they created the notice and they circulated among all the people, and it was circulated to all the people. I request all the branch people to create a handout like this on their own branches and distribute among the public. Get some sponsorship from their area and do it. And to increase the awareness, if a person with the brain death donates the organ, the local branch IMA office bearers to meet the relatives during the funeral or after in their home and thank them by giving a citation. In the IMA meetings, I request all the branches to conduct at least 5 minutes for organ donation. They need to talk about the transplant and all those things. And the organ donation workshop we are planning, and we will be coming out in the next coming months. Every month we will be having one zone, and we will do it in a grand manner. The hospital coordination meet also we are planning. And this is our regarding the Transtan. I request all of you to go to the Transtan website, Transplant Authority of Tamilnadu. This is the website address. And the organ donation, this is the emblem. And this is the card which was given before. And now is that this is the process how to do it. Actually, we have to go to the Transtan in the website, the Transtan Tamilnadu government.in, top line donor pledge click. Form 7 of organ for the tissue pledging will open. Register to pledge will open. And then Aadhaar number and mobile number we have to enter. They will verify. And then OTP verification, enter. Card open, register to pledge. Fill the personal details, edit, register. Pledge the registration, OTP verification, click verify. Download, sign and card will appear. Download the certificate. Select the language. In this English is not there. So we have to select only Tamil and download. Now the downloaded card will be in your system. You can print the card for your own. This is the process, and which we will be circulating among all the members in our WhatsApp groups. This is the latest card which they are issuing from the Ministry of Health and Welfare. This is the old card which was released from the Transtan, and now is that, see the difference. This is the Transtan old card and this is the new card. Here the all organs and every tissues and everything is mentioned. We have a Google form also for the registration for the doctors and also to the general public separately. Increase awareness about the organ donation, awards for good performing branches. Branch with maximum donor registration in our website. Branch conducting maximum donor awareness meeting to be given during the state conference IMA Con 2025. And this is what I was telling. The eye retrieval program, we call it as Kannoli Dhanam, and which we are planning to do it. The transplantation so far, this is the latest statistics which I am showing. Now, these are all the major organs. The eye is 7,566 and kidney 3,727, like that is happening. And this is the Transtan waiting list. See, kidney 7,231 is the waiting list, and liver 512, like that. And this is regarding the Chief Minister scheme. The Tamil Nadu first state to provide financial assistance up to 22 lakhs for any organ transplants through the Chief Minister scheme. It is being done. And this is regarding the organ donation activity which happened in the government Rajaji Hospital, Madurai. Organ donation Madurai on 23rd, the person had an accident. Kochade Muttaya and brain dead and organs retrieved on 26th April. Small intestine airlifted to MGM Hospital, Chennai. And liver to Vadamalayan Hospital. 2 kidney, one for Rajaji Hospital, Madurai, and one for Sundaram Hospital, Trichy. State honors given by the collector. That's what happened. And this is the small video clipping about the organ donation.
என் பேரு கல்பனா. இறந்தது என்னோட அண்ணன் தங்கராஜு தான். அண்ணன் செட்டிப்பாளையம் போயிட்டு வரேன்னு சொல்லிட்டு போனாங்க 2 வீலர்ல. போயிட்டு திரும்பி வரும்போது செட்டிப்பாளையம் அந்த ஓராட்டுக்கு போய் இதுல ஆக்சிடென்ட்னு சொன்னாங்க. எங்களுக்கு போன் நாங்க போகும்போது ஆம்புலன்ஸ் அக்கா பையன் இவங்க கூட்டிட்டு போயிட்டாங்க ஹாஸ்பிட்டலுக்கு. இங்க சுந்தராவரத்தில் இருக்கிற பீம்ஸ் ஹாஸ்பிட்டல் தான் போனாங்க. அங்க போய் ட்ரீட்மெண்ட் போயிட்டு இருந்தது. ஒரு 2 நாள் கழிச்சு அண்ணனுக்கு பிரெயின் டெத் அப்படிங்கறது டாக்டர் கன்ஃபார்ம் பண்ணிட்டாங்க. அவங்க டாக்டர் கன்ஃபார்ம் பண்ணதுக்கு அப்புறம் சரி நாங்க ஆர்கன் டொனேட் பண்றோம் அப்படின்னு சொல்லி நாங்களா முடிவு பண்ணி எங்க ஃபேமிலியில அப்பா அம்மா கிட்ட அக்கா பசங்க கிட்ட எல்லாரும் பேசி நாங்களா முடிவு பண்ணி சரி எங்க அண்ணனோட உடம்பு மண்ணுக்கு போனாலும் அந்த உறுப்புகள் மூலமா ஒரு 4-5 பேர் இந்த வாழட்டும் அப்படிங்கிறது எங்க குடும்பத்துல எல்லாத்தோட இருந்தா. எங்க அண்ணனோட உறுப்பை வச்சிருக்கிறவங்க எங்க இருந்தாலும் நல்லா இருக்கட்டும் நாங்களும் கடவுள்கிட்ட வேண்டிக்கிறோம்.
என் பேரு ராஜராஜன். நான் மதுரையில இருந்து வரேன். எனக்கு லிவர் ப்ராப்ளம் இருந்துச்சு. அதனால ரொம்ப கஷ்டப்பட்டுருக்காங்க. நைட்லாம் தூக்கம் இருக்காது, எதுவும் சாப்பிட முடியும், வாமிட்டிங் சென்சேஷன் இருக்கும், ஃபீடிங் இருக்கும், கன்ஃபியூஷனா இருக்கு. பட் என்னன்னா பெர்ஃபெக்ட் மார்க்ஸ் கிடைச்சிச்சு. ஸோ சர்ஜரி பண்ணதும் தெரியாது, முடிச்சதும் தெரியாது.
ரொம்ப ரொம்ப நல்லா இருக்கியா. எனக்கு மறுவாழ்வு தான், கடவுள் கொடுத்த மறு ஜென்மம் தான் இருக்கு. ஆத்மா தான் தெரியணும். அவங்க பிள்ளைய எல்லாரும் நல்லா இருக்கணும்.
அவங்க ஃபேமிலிக்கு ரொம்ப கடமைப்பட்டிருக்கோம். அவங்க ஃபேமிலியா அவங்க சில்ட்ரன் எல்லாரும் நல்லா இருக்கணும்னு சொல்லி என்னைக்கும் நாங்க வேண்டிக்கிடுவோம்.
வணக்கம், நான் டாக்டர் ஆனந்த் விஜய், liver transplant surgeon, Jain Hospital. Dear friends, don't throw your organs into dustbin. Please save organs and save lives. அப்படின்னு என்னன்னா, நம்ம ரிலேட்டிவ்ஸ் நிறைய பேர் இறந்து போயிடுவாங்க. இறந்து போனவங்க நம்ம புதைக்கிறதோ நம்ம சமுதாயப்படி எரிக்கிறதோ பண்ணிட்டு இருக்கோம். அதனால நிறைய ஆர்கன்ஸ் வேஸ்ட் ஆகுது. அந்த மாதிரியான ஆர்கன் கண்ணு, தோல், லிவர், இருதயம், கிட்னி அந்த மாதிரி ஆர்கன்ஸ் நம்ம டொனேட் பண்ணலாம். டொனேட் பண்ணுறதுனால நம்மளோட ரிலேட்டிவ்ஸ், நம்மளுடைய ஃப்ரெண்ட்ஸு எல்லாருமே நம்மளை விட்டு போக மாட்டாங்க. ஒரு வகையாக உலகத்தில் எங்கேயோ ஒரு இடத்துல யாருக்கும் உதவியாக இருந்துகிட்டே இருப்பாங்க. அந்த மாதிரி தானம் பண்ணுறதுல சிறந்த தானம். நம்ம மற்ற என்னதான் தானம் பண்ணாலும் அந்த தானங்கள் கொஞ்ச நேரம் தான் இருக்கும். பட் இந்த தானம் வாழ்க்கை பூரா இருக்கும். அந்த வாழ்க்கையினால நிறைய குடும்பங்கள் பயன்படும். ஸோ ஆர்கன்ஸை டொனேட் பண்ணுறதுல நம்ம கான்சென்ட்ரேட் பண்ணி அடுத்த ஜென்ரேஷனுக்கு நமக்கு இந்த நாலேஜை கொண்டு போய் சேர்க்கணும்.
Thank you. Now I invite our President, Dr. Senguttuvan sir, to give his presidential address.
Respected Advisor, Blood and Organ Donation Committee, Dr. Sukumar, Past President Dr. Abul Hassan, President-elect Dr. Sridhar, Organ Donation Blood and Organ Chairman Dr. Rajesh Babu, Honorary Secretary Dr. Karthik Prabhu, Finance Secretary Dr. Gauri Sang, and speakers of the today. I think Dr. Rajesh Babu is doing a wonderful job and regularly is conducting the Organ Donation Committee meeting to get awareness in the field of blood donation and organ donation. In spite of his repeated reminders, he is giving very good speakers for the awareness and programs. Wish him very best of luck in all his activities. Thank you, sir. Over to Rajesh Babu.
Thank you, President sir, for your nice words. Now I invite Dr. K.M. Abul Hassan sir, our immediate past President State.
Thank you, Rajesh.
Felicitations, sir.
Thank you, Rajesh. Good afternoon, all of you. Respected President, Dr. Sangutan, Secretary, Dr. Karthik Prabhu, and Dr. Sukumar, and all the office bearers of Organ Donation Committee, and my dear colleagues in Erode IMA. I'm very happy to participate in this webinar for two reasons. Number one is the subject of organ donation. It's very close to my heart. You all know that it is a very important and milestone development in modern medicine that we have invented this organ donation, organ transplantation, and the field is growing very fast. Every one of us have the responsibility to keep the flag of organ transplantation, organ donation flying, so that the society gets a benefit of this development in modern medicine. The second reason I am very happy that today our Erode IMA is joining in this webinar, and you can see that they are going to exhibit the strength of Erode academia. All the speakers of the organ donation, various topics of organ donation will be done by Erode faculties, and I think this is a wonderful, unique attempt that major branches, even not only major, even minor branches can participate with the organ donation committee and do this kind of webinar, so that the message spread across length and breadth of state. So I wish the program all success, and thank Dr. Rajesh Babu for organizing, and also congratulating him for taking such effort. Over to you, Dr. Rajesh.
Thank you, Professor, our advisor for the Blood and Organ Donation Committee.
Dear respected President, sir, Secretary, sir, and Dr. Rajesh Babu, sir, it's very nice that this time Erode IMA is sponsoring the program. And really, I congratulate Dr. Nandakumar, our Secretary, Erode IMA Secretary, who has done the job and considered all the specialists, and they're all going to talk. It's I've seen the speakers were all very nice. Let it continue. I will stop this because there are so many speakers. A nice topic is there. Let them continue. I wish them all the best. Thank you, sir.
Thank you, Sukumar sir. Now I invite Dr. B. Sridhar, our State President elected 2025. I think President Sridhar sir is busy, I think. Now I invite our State Secretary, Dr. Karthik Prabhu sir.
Thank you, Rajesh Babu sir. Most respected President, immediate past President sir, and all the leaders, Sukumar sir, Rajesh Babu sir, everybody. Nalla topic sir, and you have carefully chosen almost everything about organ donation you have covered. So very nice, and you are doing it very actively. Best wishes sir, all the best for your program. Thank you sir.
Thank you, Karthik Prabhu sir, for your felicitations. Now I invite Dr. Gauri Shankar sir, our Honorary State Finance Secretary sir. Okay. Now we will straight away go to the program. Now I invite Dr. Nandakumar sir to give a small introduction about how he was able to arrange this program. Because since immediately I asked him about arranging the speakers, he just like that, he arranged 7 speakers continuously. I don't know how he was able to get all the tuck. Immediately on the next day, he gave all the speakers' name and topics also. And he wanted to include a human milk bank also. So it was a very nice thing that he arranged this. Yes.
Yes, sir. Yes, sir. Dear colleagues and leaders.
At the same time, sir, Nandakumar sir,
Yes, sir.
introduction, you can start conducting the program, sir. From now on,
Okay, sir.
I will be there, but you
Okay,
start
sir.
introducing each and every speaker, and then just you give some few words about them, and then you start.
Okay, sir. Okay. So first of all, I thank the Blood and Organ Donation Committee, Dr. Rajesh Babu sir, Chairman, and Dr. Sukumar sir, Advisor, and Dr. R.K. Rashmi, Co-convener, and for giving opportunity to Erode IMA to present this Zoom CME. And we thank our Erode IMA leaders like Dr. Abdul Hassan sir and C.N. Raja sir and Sukumar sir for their continuous support to next generation to lead IMA. And that's the reason we are able to organize this type of Zoom CMA with state leaders. And our sincere thanks to our President, Dr. Senguttuvan sir, and our Dynamic Secretary, Dr. Karthik Prabhu sir, and Treasurer Gauri Shankar sir, and our Vice President, Senior Vice President, Dr. Madhavan sir, and the President-elect, Dr. Sridhar sir, and all the state leaders, patrons, for your success, the continuous sustained effort. That's the reason our Tamilnadu IMA is doing this excellent job. And we have our own practice. Despite that, and you have developed such a great social activity and awareness to our own colleagues and the people for the upliftment of our society. First of all, our sincere thanks to you all, sir, for your sacrifice and time you given to this type of activities. So first, we introduce today's first speaker, Dr. S. Meghala, MD, Department of Anatomy, Assistant Professor, Erode Government Medical College. And Madam has conducted various organ donation program through Erode Medical College. And her topic is body donation in Tamil Nadu Government Medical College. We invite Dr. Meghala Madam to present her topics.
Thank you, sir. Very good afternoon to one and all present here. I am very honored to present the topic on body donation. So there are three sources of corpse for the government medical institution. In Latin word, corpus meaning body, human dead body. The first source, we can get the three sources of human dead bodies, that is corpse for the teaching medical institution, approved teaching medical institution. The first one is we can get it from the other nearby medical college. The second source is unclaimed and unknown or unidentified corpse. The third source will be our voluntary body donors. Regarding unclaimed or unidentified unknown corpse, in previous, in olden days, the unclaimed unknown bodies are disposed by corporation. Nowadays, all the deans of government medical institution requested the Directorate of Medical Education to hand over the unclaimed bodies to the teaching medical institution. So DME requested all the deans and RMOs of government medical institution to ensure the cold storage facilities available in the FM and also in the anatomy department. So we can keep the dead bodies in the freezer boxes available in the FM and anatomy department. So the unknown person who got deceased and found by the local police or any volunteer, any trustee people can identify by the trustee. The unknown bodies can identify by the trustees and bring to them to the nearby government institution, either by GH or to the teaching medical institution. So in the emergency department, they put a casualty number for that unknown person. They admitted the unknown person. If the admitted person undergo so cause of death will be given by that treating doctors. And also the police should inquire about that person, unknown person. யாராவது தெரிஞ்சவங்க இருக்காங்களான்னு அந்த போலீஸ் வந்து பார்க்கணும் சார். சப்போஸ் 1 monthக்குள்ள within 1 month period there is no one is claiming the body now, that body is hand over to the Department of Anatomy. So I'll bring the body to the Department of Anatomy. The HOD of Anatomy department should receive the casualty number put for that unknown person while getting admitted, and also no objection certificate which is received from the local police inspector, and also cause of death which is received from the treating doctors. So these are all the registers we maintained in the Department of Anatomy, Government Erode Medical College. Unclaimed cadaver embalming file, unclaimed body register. So this is the example for unclaimed or unknown body, which is received in the Department of Anatomy in Government Erode Medical College. So Palanichami, 86 years old, வயது மூப்பின் காரணமாக அந்தியூர் மசூதி அருகில் நீண்ட நாட்களாக திடீரென உடல் குறைவு ஏற்பட்டு அந்தியூர் அரசு மருத்துவமனையில் சிகிச்சை பலனின்றி 3/5/2024 இறந்து விட்டதால் மேற்படி பழனிசாமியின் பிரேதத்தை பெற உறவினர்கள் யாரும் வராத காரணத்தால் ஈரோடு அரசு மருத்துவக் கல்லூரி மருத்துவமனை மாணவர்களின் பயன்பாட்டிற்காக அவரது உடலை தானம் செய்ய மருத்துவக் கல்லூரி முதல்வர் அவர்கள் மூலம் உறைவிட மருத்துவர் அலுவலரிடம் ஒப்படைக்க பரிந்துரை செய்யுமாறு கேட்டுக் கொள்ளப்படுகிறது. So this is given by local police inspector to the HOD of anatomy. So any unclaimed or unknown bodies which is received in the government medical institution properly handed over to the HOD of anatomy through RMO. So this is the cause of death which we received for the Subramani patient. So this is the first source. So during unclaimed or unknown, unidentified dead bodies, so these are all the documents needed for the HOD of anatomy to keep the bodies for further use in the Department of Anatomy. The first one is casualty number. The second one is no objection certificate from the local police inspector. The third one is cause of death, which was given by the treated doctors. So this is one body which is handed over to the Department of Anatomy through trustee people, Akshayam Arakattalai. So second source will be voluntary body donation. So voluntary body donation means the person gives the whole body after his or her death. Before giving, he or she has to discuss with the family members, next of kin, or close relatives or legal heirs for her willingness to donate his body to the nearby government medical institution. So this is governed by our Anatomy Act. So Anatomy Act is a legal act that deals with the storage of dead bodies in the government teaching medical institution. So body donation campaigns, programs will be conducted through rallies, CME posters, pamphlets, and students' involvements also, MBBS students' involvements. So procedures to be followed at the time of registration. The voluntary body donor form available in the Department of Anatomy. So the person come to the medical college and approach the HOD of anatomy, say about his or her willingness to donate his body. And so during that process, he or she approach the Dasildar and get the legal hire certificate. That legal hire certificate states that the no objection from the legal hires, and also with the 2 witnesses. And also we need a HIV hepatitis B blood test of voluntary body donors. And also we need photo, identification certificate, and identity proof like Aadhaar card of voluntary body donors, and also from the legal hires, identity proof of legal hires. So this is the voluntary body donor registers and forms available in the Department of Anatomy. So this is the first letter, willingness letter. So this person is willing to donate his body to the Government Erode Medical College. So she has to show the willingness in the form with the 2 witnesses. So this is from the this is Varis Chandadal from the Dasildar office, stating that these are the legal hires. These 3 persons are legal hires to that voluntary donor. So இவங்க அலோ பண்ணிட்டாங்க அப்படிங்கிற ஒரு சான்று, வாரிசு சான்று. Plus that person giving the willingness letter, no objection for donating his body to the dean of the government teaching institution, and also blood test reports, ID proof. So after registering his body in the Department of Anatomy, the HOD of Anatomy should give the donor card to the body donor, and also give the acknowledgement letter stating that this is the registration number of that person. So after a successful registering with these all documents, the legal hire certificate from the Varuvai Vattachiyar Alugulagam, and also no objection letter from the body donor, and also no objection letter from his or her legal hires, and also blood investigation, and also identity proof of all the legal hires and also that willing donor. So after all successful registration, the HOD of anatomy should give the body donor card and also give the acknowledgement letter stating that the registration number. So this is the acknowledgement appreciation letter from the HOD of anatomy to body donor. So these are all the register maintained in the Department of Anatomy for voluntary body registration. So this is one example, Mr. So-and-so, address, Aadhaar number, mobile number. So acknowledgement sent to this person, the registration number is 038. Also, we additionally added nowadays to give the body donor card to the voluntary body registered person. So this is the body donor card available in the Department of Anatomy, Government Erode Medical College, stating that the name, donor, body donor, Aadhaar number, phone number, and residential address and cadaver code. So procedures to be followed after the death. So before death, the person should discuss with his or her willingness to the family person regarding his willingness to donate the body to nearby government medical institution. So legal hires should give the no objection letter to the HOD of anatomy. After that only he can donate his body, even though he is willing, but the legal hires didn't give willingness, the person didn't donate பண்ண முடியாது sir. The procedures to be followed after the death. So after the death, the legal hires should intimate the HOD of anatomy regarding the time of death, manner of death. So the body should be handed over to the Department of Anatomy within 6 to 12 hours. So we can provide the free transport facility within 30 kilometers, bring the died person. So eye donation has been done before body donation. It is prior to body donation within 6 hours. So this is for registered voluntary body donor. Suppose unregistered voluntary body donor, the legal hires provide willingness to donate his mother or any relative body to the teaching medical institution. The death of the person will be happened in that institution only. So cause of death given by the treating doctor of that college only. So we can give the appreciation certificate and ஒப்புகை சான்று after donating his or her body. So based on the ஒப்புகை சான்று only, he can the relatives, legal hires can claim the death certificate from the municipal corporation. So the transported body is embalmed and preserved in the tank for 5 years. The remains are disposed scientifically, either by burial method or incineration. For acceptance of voluntary body donors, there is no age limit, upper age limit. For rejection, death due to unnatural causes like poisoning, accident, suicide, and also decomposed bodies. We won't accept decomposed bodies and autopsied bodies. Suppose unclaimed bodies found in the roadside or unknown bodies which is found in the roadside, which is brought by the local police inspector, it should be autopsied. We cannot accept the autopsied bodies from the FM department. So death from the contagious diseases like COVID-19, HIV, prion disease, advanced cancer, advanced bed sores, bacterial viral infections, gas gangrene. So these bodies are not accepted in the Department of Anatomy. So these are all the appreciation letters given to the legal heirs of body donors after giving this or her body. So thank you for listening my presentation, sir.
Thank you, madam.
Thank you, madam. We will have our questions at the end of all the speakers.
Okay, sir.
So
Thank you,
we
sir.
will be online, and then we will ask some questions. There are a lot of doubts we have now. So we will clarify one by one later. Nandakumar sir?
Yes, sir. Thank you, Magala madam, for your wonderful presentation. Now our next speaker, Dr. Saraswati Vijay Kumar, MD Pathology, Consultant Pathologist and Head of Laboratory and Blood Center, KMC Specialty Hospital from Erode. Topic, voluntary blood donation, the cornerstone of safe and sufficient blood supply. Welcome, madam. Welcome to the CME.
Good evening, everybody. It's a great honor to be a part of this CME program organized by IMA Tamilnadu State Branch. I'm here to talk about voluntary blood donation, which forms the cornerstone of a safe and sufficient blood supply. Through this program, I intend to create an awareness about the concept of safe blood and awareness about the need to donate blood regularly, and create an awareness of a healthy lifestyle and maintaining a healthy hemoglobin levels, and how to ensure an adequate supply of safe blood. The transfusion of blood products is a common medical practice that saves the life of people who are critically ill, who are undergoing surgeries, who are suffering from cancers or traumas. Easy access to safe blood is also essential to reduce maternal mortality due to postpartum hemorrhage. The transfusion services, they face a dual challenge of ensuring a sufficient blood supply and also ensuring the quality and safety of the blood products. Even with all of today's technologies, there is no substitute for blood. Someone has to give blood in order for someone to receive it. Blood donation is actually a gift of life. One donation can save as many as 3 lives. And for an adequate and reliable supply of safe blood, we need a stable base of regular, voluntary, unpaid blood donors. So what is this voluntary blood donation? It is the process where the individuals willingly donate blood to help save lives. They do not receive any payment in the form of cash or in kind, which could be equated with money. Small tokens, refreshments, travel cost reimbursements are all compatible with voluntary blood donation. Healthy, responsive, and motivated blood donors are the backbone of this program. The voluntary donation plays a crucial role in public health by ensuring a steady supply of the safe blood. And voluntary donors are often healthy, so this enhances the safety of the blood products. And studies have shown reduced incidence of transfusion transmissible infections among voluntary donors when compared to other donors. So commercialization of blood donation is a breach in the fundamental principles of altruism, which the voluntary donation enshrines. The professional donor system was banned in the country with effect from 1st January 1998, as per the Honorable Supreme Court judgment. Government policy aims at catalyzing a situation of near total voluntary blood donation and phasing out even the replacement donor system. A campaign named Naya Saal, Naya Savera was launched with an objective to achieve 100% voluntary blood donation in the state. So the blood donors can be categorized by the donation method, by the components donated, and by the blood type. By the donation method, they are called voluntary unpaid donors who do not receive any financial gains. Relative or replacement donors who donate for family members or community members are sometimes driven by persuasion or even financial gains. And finally, the paid or professional donors who receive money for their blood donations. By the components donated, they can be called whole blood donors or platelet, plasma, or red cell donors. And by the blood type, we have the O negative or universal red cell donor. This O negative red cells, they do not carry any surface antigens, so they can be safely given to patients of any blood groups. And finally, you have the autologous donors who donate for self-use at a later date. So the voluntary blood donors, they are further categorized into new voluntary donors, lapsed voluntary donors, and regular voluntary donors. New voluntary donors are the ones who are donating for the first time. Lapsed donors, they have less than 3 donations and no donation in the previous year. And regular voluntary donors have donated more than 3 times. The last donation was in the previous year, and they usually donate once a year. So why voluntary donation is safe? The voluntary donors, they are motivated by altruism and the desire to help others and by a sense of social responsibility. They are not under any pressure by the hospital staffs, family members, or community to donate blood. So they have no reasons to withhold information about their lifestyle or medical conditions that make them unsuitable to donate blood. The only reward they get is personal satisfaction, self-esteem, and pride. Repeat voluntary donors, they are well informed about the donor criteria, so they are more likely to self-defer if they are no longer eligible to donate blood. And they form the first line of defense against TTIs. Replacement or relative donors, they are usually family members or friends of the patients who are in need of blood. And sometimes if the relatives are unwilling or unsuitable to donate blood, and if they are unable to find a suitable replacement donor, they may even resort to paid donors. The family members, they are not well informed about the conditions that make them unsuitable to donate blood. And in their eagerness to save the life of a loved ones or in fear of distressing a family member, they may even conceal information about their health status or lifestyle. The donation of blood on replacement basis has impact on its further use also. Families who have provided replacement donors may expect transfusion to be given irrespective of the need. This puts unnecessary pressure on the physicians to transfuse even if it is no longer needed. Paid donors are the ones who receive payment for their blood. They are primarily motivated by monetary gain rather than the desire to save lives. They come from the poorest sections of the society and become paid donors due to economic difficulties. So they are vulnerable to exploitation and commercialization. They often lead a lifestyle that exposes them to HIV and other infections. Highest prevalence of TTI are found among paid donors. And in order to protect the income from blood donation, they may hide reasons when they become unsuitable to donate blood. The professional donors are often malnourished and in poor health and may donate more frequently than recommended, risking their own lives. The blood center's primary concern is to ensure the safety of the blood and the safety of the donor. Safe blood gives life, whereas unsafe blood gives infections and reactions. To ensure the safety of the blood, a strict donor screening criteria is applied to select the suitable donors. The blood is collected under aseptic precautions using disposable sterile bags and needles. And after collection, it is tested for TTIs. Once the TTI turns negative, the blood is separated into components and stored at appropriate conditions. And before issue, proper cross-matching of the donor and the patient sample is done to ensure that right blood is given to the right patient. Regarding donor safety, every donor undergoes a focused health examination with each donation, which includes the vital signs monitoring, a blood test for grouping, and hemoglobin estimation. This helps to assess if it is safe for the donor to donate blood. And every healthy adult has around 5 to 6 liters of blood in their body, so they can safely donate 350 to 450 ml once in 3 months. And our body recovers the donated blood very quickly. Blood plasma returns to normal volume within hours, platelets and white blood cells within few days, and the red blood cells within few weeks. The process is very quick. It takes only 5 to 10 minutes, and the entire process is done under sterile aseptic precautions. So it is safe for the donor. So these are the examinations, which includes a general physical examination, vital sign monitoring, blood grouping, hemoglobin estimation, and screening for the transfusion transmissible infections such as HIV, hepatitis B, hepatitis C, syphilis, and malaria. After screening, and if the screen is negative, the blood is separated into the components, namely packed red cells, fresh frozen plasma, platelet concentrate, and cryoprecipitate. It can also be used as a whole blood for exchange transfusions in babies, accident victims with severe hemorrhage, complicated deliveries, and some specific surgeries. The whole blood is stored at 2 to 6 degrees in the blood bank refrigerator. The packed red cell, it is also stored at 2 to 6 degrees. It is used for patients with severe anemias. Fresh frozen plasma is stored at -40 degrees in the deep freezer. It is used for clotting disorders and burns. Platelet concentrates, they are stored at room temperature under constant agitation. They are used for patients with severe thrombocytopenia due to cancer, dengue, etc. Cryoprecipitate is a fractionated from plasma. It contains fibrinogen, von Willebrand's factor, factor 8, and small quantities of factor 13 and fibronectin. It is used for clotting disorders due to afibrinogenemia, hemophilia, obstetric and cardiothoracic hemorrhages. So after donation, we need to take care of the body to support the recovery process. The post-donation care includes adequate hydration, eating a well-balanced diet, and taking plenty of rest. Drinking lots of fluid can help to restore the blood volume and also prevent dehydration. Eating a nutrient-rich diet, rich in proteins, iron, and vitamins, help the body in the recovery process, and avoids high strenuous exercises or activities which can deplete the energy levels. If the site of phlebotomy bleeds, reapply pressure on the band-aid, and the band-aid can be safely removed after 4 hours. If any of the donor sample tests positive for the TTIs, then the tests are repeated in duplicate. A complete confidentiality is maintained about the test results. Only the donor is informed. Then they are referred to health experts for further management and follow-up. Donor notification and counseling is essential to maintain the safety of the blood and comprehensive donor care. So what is the donor eligibility criteria? Every donor must fulfill certain criteria to become eligible to donate blood. The age should be between 18 to 65 years and weight above 45 kgs. The hemoglobin level should be above 12.5 grams per deciliter. The temperature should be 98.4 degree Fahrenheit, and blood pressure, systolic BP between 100 to 140 and diastolic 60 to 90 millimeters of mercury. The heart rate should be regular between 60 to 100 beats per minute. The donor should be in good health and must have had a good night's sleep. They should take a light meal before donation and be mentally prepared to donate. The deferral criteria, these are the reasons why some individuals are temporarily or permanently becoming ineligible to donate blood. These criteria aim to protect both the donors and the recipients. To protect the donors, they prevent them from donating if they're not in good health. For the patients, they help in ensuring a safe blood supply by excluding individuals who are at risk of transmitting the infections. The deferrals may reduce the pool of the potential donors, but they're essential for maintaining the safety and quality of the blood supply. So temporary deferral criteria are last donation less than 3 months, tattooing or body piercing in last 6 months, malaria or typhoid in the last 3 months, taking any vaccination in the last 2 weeks, and if you have any risk factors for HIV or AIDS, such as unsafe sex or IV drug abuse in the last 6 months. And female donors are temporarily prohibited from donating during pregnancy, lactation, and during menstrual periods. The permanent referral criteria include abnormal bleeding disorders, diseases of the heart, kidney, liver, and thyroid, epilepsy and mental disorders, tuberculosis, asthma, cancer of any organ, uncontrolled hypertension, and type 1 diabetes. So what are the benefits of blood donation? Blood donation is not just about helping others, it is also a pathway to a healthy lifestyle. Every donor undergoes a mini health screening with each donation for free. This health screening includes vital signs monitoring and other blood tests, which can easily identify potential health risks of the donor. And repeat donors, they have reduced risk of heart attacks due to reduced blood viscosity and also the iron levels. It is also beneficial for weight management. Each donation burns around 600 calories as our body works to replace the donated blood. And within 48 hours, the body begins producing new blood cells, which improves the overall vitality of the donor. Blood donation also reduces the stress levels and improves the emotional well-being. The public and private sectors are taking various steps to encourage the voluntary blood donation. 1st October every year is celebrated as the National Voluntary Blood Donation Day. The blood donation agencies are organizing workshops to educate people about the benefits of donating blood. With huge population of youth, blood donation camps are conducted by hospitals and organizations in colleges and corporates. Blood donors and their family members, they are given priorities in many hospitals in case of emergencies and accidents. And Government of India has launched an online portal by name e-Raktakosh in the year 2016. It is a web-based mechanism which integrates all the blood centers in the state into a single network. This provides information about the camp and availability of the blood products in the hospitals throughout the country. So what can we do as an individual? Make blood donation a habit. Donate regularly once in 3 months to commemorate special days like birthdays and anniversaries. Motivate others to donate blood and refer your friends and relatives to blood donation camps. So I'd like to conclude that blood donation is a remarkable example of how helping others can directly benefit our own health and well-being. This simple act can reduce heart attacks, burn calories, and also improve our psychological well-being. The continuous demand for blood and limited supply of blood products make the regular voluntary donation crucial for maintaining an adequate supply. Voluntary donation is the most cost-effective way to ensure a steady supply of safe blood. So becoming a voluntary donation is not just a single-time act. It is about joining a community of people who consistently help others and also improve their health. So it is about fostering community, solidarity, and social responsibility. I take this opportunity to salute our Dr. Sugumar, who has donated for more than 192 times in his lifetime. Thank you, sir.
Thank you, madam. It's a wonderful presentation. And now our Dr. Rajesh Babu sir will give some feedback.
Thank you, Dr. Saraswati madam, for your nice lecture, and we will have questions at the end of all the 7 speakers. Nandakumar sir.
Thank you, sir. Thank you very much, sir. Now we invite Dr. Rajesh, MD DNB, nephrology, consultant nephrologist and transplant physician from TNSB Specialty Hospital, Erode. And his topic is challenges in the disease donor transplant. We welcome Dr. Rajesh for this Zoom CME conducted by Tamilnadu Blood Organ Donation Committee, Tamilnadu State Board, IMA.
Hello, sir. Thanks for welcoming me. At the outset, I would like to extend my appreciation to the IMA and Organ Donation Committee for having selected this topic. Not that one. That was the page. So is it clearly visible, sir, my slides?
Yes, sir.
Okay. So myself, I'm Babu, nephrologist at CMCHIS Erode. I'm going to speak about challenges in disease donor transplant. So when you look at the Seek India study, that is a study of CKD epidemiology. CKD epidemiology. So the prevalence of CKD is around 17% in India. When you divide that as a stage wise, even at stage 4 and 5 of CKD, it's around 1.6%. So considering a population of 150 crores, if it's 1.6 crores means it's around 9 crores. So 9 crore people are already in stage 4 and 5 of CKD who will be ending up in hemodialysis in the next few months or years. So that much is the burden of CKD in our country. So many people have the option of going for live organ-related transplant from the related donors. When people don't have the choice, they will have to be in hemodialysis for years together. So those people, the only life choice is that they will have to register for disease donor transplant. But the disease donor transplant, looking at the need of disease donor transplant and number of donors being generated, the gap is widely huge. So because of this, almost 4 lakh people die every year in India waiting for renal transplant. When you look at the disease organ donation rate, the donation rate is around 0.5 per million population in India. So whereas in Spain, it's around 49.6, which is the topest, the highest country for organ donation. Thereafter followed by US and other European countries. Even the global average is 7.9 per million population, but whereas India, it's around 0.5, which means around 18 times lesser than the global average. So what is causing, what makes the statistical difference? So there is a plethora of reasons. That is what my presentation is all about. I'm not going to speak in detail. I'm just going to give a gist of each challenges. So these are the list of challenges which we face for disease donor transplant. The first challenge being the trust deficit and many other challenges. The challenges which I'm going to speak, I have just highlighted in yellow colors. So for the trust deficit, role of media. So first, when we tell the patients about brain death, and if at all whether they are willing for organ donation, the thing is that they will be thinking that the doctor is either misusing or misappropriately using their relative. So the main reason for trust deficit is media. Before blaming the media, so I will just highlight the positives of the media, how powerful the media is. So you can remember this picture, especially people. This is Mr. Hemanathan who met with a road traffic accident, and this is their family. The doctor's couple is both his father and mother or doctors. When he was declared brain dead, his father and mother decided to go ahead with brain death donation. So this was in the year 2008, when even the medicos were not aware of the brain death organ donation in many colleges. So thereafter, there was a movie released called as Chennai Lorana, which also portrayed the difficulty in organ transplantation as well as difficulty in patient counseling regarding the brain death. So because of all these, the impact of media was so high that in the year 2008, there were only 7 donors. That is when the Hemanathan started it in Karur. So within the next year, the organ donation increased by 8 times. That is, it's 59. Thereafter, it has started increasing in Tamil Nadu every year, but not more than 2 times. So the first year, it was around 8 times. So every year, the organ donation rate was increasing. This predominantly because of media. Now again, going to the next side of the media, we had few other movies being released which portrayed organ donation in negative way. They were either blaming the medical faculty or were speaking about the mafia involved in organ trafficking. So there are some movies which has even showed that when you're met with a road traffic accident, when you will be shifted in the ambulance, you will be given carbon monoxide instead of oxygen, thus making the patient brain dead, thereafter making them to promote organ donation. So because of these kinds of movies and web series, there were 210 withdrawal of consent for organ donation. So if at all I'm interested in organ donation, even before my death, I can enroll myself for organ donation after my death or brain death. So this is called as voluntary organ donation. So after these things, 210 people have withdrawn their consent. Even my sister, she has withdrawn the consent. When I asked that, she was stating that she is a B negative blood group. It's a very rare blood group, so she will be killed for the sake of organ donation. So the trust factor with the public, which we took many years to build, was easily lost over the past few years. So because of that, when you look at the transplant statistics, the organ donation rate, organ donors peaked at in the year 2016. Thereafter, it started declining gradually. Okay, in the year 2020 and 21, it's maybe because of COVID, but every year it was declining rather than increasing. So the reason is suspicion of misuse by the doctors. So 60% of the attendees believe that we are misusing their relatives who are getting admitted. So some people believe that if they are giving consent for organ donation, the doctor may not put their best effort to save the patient. So these people are denying because of this suspicion of misuse. So when we speak about brain death, so this is a way how the patient will be in the ICU. So a patient in coma as well as in brain death, both will be looking similar. So people are not aware between the difference between coma and brain death. So when we explain the attenders, say for example, an intensivist or a neurosurgeon or a neurologist are explaining to the attenders that the patient, there's no point in trying further because he's having a massive bleed and he's brain dead. So you have either two choices: either you can take them home or you can donate organs. So by that time, when even if the attenders are willing to donate, they'll be asking for last chance to come and see the patient inside the ICU. So they will be coming inside the ICU, and many other relatives also will be coming and coming inside the ICU. They will be touching the patient. If the patient is warm, they will think that there is a chance of survival. Doctors are falsely claiming brain death. If the body is cold, they'll be speaking like already he's dead. He has been just put on ventilator just for the purpose of money. They'll be looking at the BP, pulse rate, everything will be all right. So they will be thinking that he is being declared brain dead only for the sake of organs. That is, people don't understand the concept that if you are on ventilator, especially in brain death, if you are disconnecting the ventilator, the patient may go for arrest within the next 3 or 5 minutes because there is no voluntary respiratory effort. So because of this, because of the patients, attenders are having trust deficit. Even if the doctors are explaining, the patients are having a misunderstanding with doctors. Because of this, nowadays, many doctors, especially in private hospitals, even if they are coming across some 10 brain deaths, they are just explaining to only 3 patient attenders. Rest of the 7 we are not even explaining them. The hands are tied for the doctors. So the second challenge is lack of knowledge about the brain death. The first brain death was declared, the concept was first coined in Paris. That was the first time they identified a concept called as brain death. This was in the year 1959. So before that, people were thinking that if it's a death, the death is either because of cardiac arrest or because of respiratory arrest. So after this identification of brain death concept, the laws have been reformed to include the terminology brain death also is a death, is a form of death. So first year, 1959, it was identified in Paris. Thereafter, in 1968, they arrived at a consensus definition for brain death. Again, 1977, Australian laws were reformed. 81, US laws were reformed. So till that time, the brain death was not, it's not a concept in India. So 1994, the Transplantation of Human Organ Act was reformed. So thereafter, so previously, the definition for deaths was determined by 3 laws in India. One is the Registration of Birth and Deaths Act in the 1969. Next one is IPC 1862, Section 46. And then in the year 1994, after this amendment, so even the brain death was also included in the definition. So I'm just quoting this definition. The crux of this definition is that the year 46 IPC and 1969 Act, both were brain death was not included. It is because of the TOVA Act in the 1994, even the permanent disappearance of all evidence of life by reason of brain death or in a cardiopulmonary sense at any time after live birth has taken place. That's the definition of death right now. So nowadays, even people studying in the remote colleges, they are not aware about the concept of brain death. When people are doing their undergraduation or post-graduation in a hospital where the brain death organ donation is already happening, they are getting acquainted to the terminology, whereas people even remote areas, they don't know the real meaning of brain death. Even when I go for a talk anywhere, when I ask the students or on non-medicals, so if you think that whether you're thinking a brain death patient is alive, everyone always raises their hand that brain death means the patient is still alive, only his brain is not functioning. But that is not the case. Brain death means a death. So if we have to address this challenge, this TOVA Act should be included in the curriculum of schools and even undergraduate curriculums. Going for the third challenge, the socioeconomic factors. In public sector hospitals, we need, whenever we have a road traffic accident, majority of the accidents, patient will be shifted to the hospital by 108 ambulance, who will be first brought to the government hospitals. So government hospitals, if they have to save the patient, then they have to shift him to the ICU, then radiological imaging, they have to find whether it's a bleed or not, then we have to check for whether there's a brain death. If it is a brain death, then they have to reconfirm brain death after 6 hours. So it's quite a lengthy process. It may almost take 24 hours. So round the clock, we need to have intensivists, and emergency physician in a government hospital to increase the number of organ donors. So this is a very sensitive issue where only trained people can explain to the attenders that the patient is brain dead. And if you're told you're willing, you can go for organ donation. It's not very easy to convince the patient attenders. So you need to have a grief counseling education. And going for the non-financial incentives, this is one thing which government can do to increase the organ donation. Say, for example, if a patient is donating the organs, they are not going to get any incentive. Rather, if they are donating, and in their family member, if someone is going for renal failure in the future, and he is planning for enrollment in the organ donation rankings, he will be in the rank 1000 or 1700. See, if his father has donated already brain death organ donation, then he can be given some credit points. So because of which he can come from 1700 to 1500 rank. So this can encourage people to donate organs. Is a kind of concept which is already working place in Israel and some other countries. And the second thing is credit points. So you have to give credit points for the doctors who are involved in declaring organ donation, involved in preserving the organ function, because once the patient is brain dead, there will be lots of hormonal milieu, taking the patients for shock and then endocrinological shock, everything. So it's not easy to maintain a patient for 24 hours or 48 hours in ventilator with lots of vasopressor supports and then even hormonal supports. So the doctors who are taking care of these patients should be given some credit points. These credit points can be used for their promotion. Say, for example, if at all you want to be promoted from assistant professor to professor, you have to publish thesis or something else like that. Likewise, these credit points also should be included. Also, if at all if the doctor, he's say, for example, he's from Dindigul district, who is working in Erode, every day he's traveling from there and going there, these credit points can be used for giving posting even at their hometown. So that is a way how a government can really encourage declaring more number, identifying more patients and saving them and declaring the patients. So regarding the private hospital, there is a huge lacuna in cost of maintenance. When you look at the Organ Transplant Act in Tamilnadu and then guidelines, say, for example, if a patient is having a massive intracranial hemorrhage, is not brain death, but there is no purpose in doing surgery, because even if I'm doing surgery, the patient will be in a vegetative state. So sometimes the surgeon feels, okay, there is no point in going ahead with the surgery. He's going to have extremely guarded prognosis. So he'll be going to the attenders and telling them, yeah, he is going for brain death, probably next 24 hours or even after 12 hours, he'll be going for brain death. So the attenders will be willing to donate the organs. So at this point, the problem starts. So because in private hospitals, the cost of ICU is humongous. It starts somewhere by 15,000 to 50,000 per day. So who is going to bear this cost? Sometimes the patient will expire will be going for brain death in next 24 hours. So the hospital will be taking all the expenses. Sometimes it may take even 3 to 4 days for the brain death. So now there is a misunderstanding which is going to happen. So that is one lacuna which is not addressed in our guidelines, so which we have to address to increase the donation. Second thing, there is a lack of interest among doctors. As I told you in the previous slides, when a doctor is declaring, people are not in the mood to accept this declaring. Rather, they just doubt the doctors whether we are doing this for commercial purposes. Fourth challenge is delays in procurement. So when I declare a patient brain dead, all their relatives will be coming to the hospital. Few of their relatives will be going to the patient's home. They'll be making all the arrangements for cremation. So here the brain death declaration process will be taking 24 hours. By this time, the parents will be exhausted after crying, even their relatives. So nobody can wait for a long time. So even people who have accepted for organ donation, after some 6 to 8 hours, again, they will be revoking their decision and they will be denying brain death organ donation. So we have to make certain amendments in the law so that we can make we can just increase the time of organ procurement. Regarding the organ transport, yes, it's not at all a problem right now. But the problem is, say, for example, we belong to the West Zone. The Erode belongs to the West Zone. If a brain death is happening in Dharmaburi, so I have to go to Dharmaburi but the travel time is 4 hours to 5 hours. So I have to go to Dharmaburi. I have to collect the donor's sample. By the meantime, I have to take another blood sample that is from a dialysis patient from Erode. I have to collect these both samples and I have to send the cross match to a Coimbatore lab. So this transportation per se will take around 10 hours, 7 to 8 hours. By the time the second brain death declaration, by the time of procurement, only then we are getting the cross match negative report. So we need certain window period for the reports to come. So looking at the deceased organ donors in India, the Indian organ donation is, though it declined, thereafter it's again increasing, reaching a peak of 1,037. But from my point, with our potential, it should be somewhere around 10,000. It should be 10 times more than what is happening right now. When looking at the 2022 versus 23 data, this is the number of kidney transplant which happened in the 2022, of which 1,500 is deceased donor, 10,000 is live donors. The next year it has increased. So Tamil Nadu is doing a really good job. When I was some 3 or 4 years back, Tamil Nadu was the topper in the list. So if in case of Europe, almost 15%, that is 15% of total organ transplantation is because of deceased donor organ transplantation in kidneys. This should be increased to 30 to 40%. We have that potential. So this is a statewide deceased donor transplant. You can see in the 2012, 13 and 14, Tamil Nadu topped the list, and there is no one to compare with Tamil Nadu because we were far ahead of other states. So when you look at Uttar Pradesh was doing only 7 transplants. Just imagine their population is somewhere around 21 crores. That is 3 times more than Tamil Nadu. So they should have been doing around 400 transplants, but they were doing only 7 transplants. We were proud of Tamil Nadu in that day. On those days, Tamil Nadu government and the organ donation committee were making lots of awareness things, and they were coming. They came out with help, because of which Tamil Nadu always topped the list. But now, this is the 2022 data. You can look at this. Telangana is topping the list, followed by Tamil Nadu, and then Karnataka. Last years, again, Tamil Nadu has gone to the 3rd place. So these are the challenges which we have to address to increase the number of transplant in Tamil Nadu. Thank you.
Thank you, Prabhu Murugesan, consultant nephrologist, for your excellent presentation. And Dr. Rajesh Babu, sir.
Sir, you continue, sir. We will have questions at the end.
Oh, okay, sir. Okay, sir. And next speaker, Dr. Kannoli, Department of Pediatrics from Erode Government Hospital. And our topic is regarding human milk donation, that is human milk bank. Welcome, Dr. Kannoli, madam. She's a consultant pediatrician from Department of Pediatrics, Erode GH.
Thank you, sir. Human Milk Bank, otherwise known as Comprehensive Lactation Management Center, which is our CLMC established in SNCU for running for past 1 year. And what is the CLMC? CLMC is the Center at Health Facility for providing lactation support and lactation management for all mothers within the hospital. And it is providing facility for collection, screening, processing, and storage, and dispensing of donated human milk for babies without access to their own mother, and providing facility for expression and storage of mother's own milk for consumption of her baby. Donor human milk is the milk expressed and voluntarily donated by lactating mother other than the biological mother of the recipient. The purpose of establishing CLMC is and the exclusive breastfeed had the potential to prevent 13% of under-5 death, and it reduces 22% of all newborn death. And in India, 27 million babies are born every year, of which 3.5 million babies are preterm and 7.5 million babies are low birth weight. 47% of babies newborn are small for gestational age. These vulnerable babies have the difficulties for feeding at the time of birth due to their medical illness.
So if direct breastfeed is not possible, the next best alternative is expressed breast milk. If expressed breast milk is not available, is not adequate, we are forced to give formula milk with the risk of sepsis and necrotizing enterocolitis, which is commonly seen in preterm babies. India has a network of 661 SNCUs, in which 47% of babies in the admission, 47% babies admitted for preterm care, and 50% babies are admitted for low birth weight care. So in 30 to 50% of neonates in NICU and 10 to 15% of babies in SNCU are in need of donor human milk. They are depending on donor human milk for their feeding, for the survival and quality survival. So availability of safe donor milk at SNCU is critical to ensure that every sick newborn preterm babies receives human milk within the first hour. Donor human milk play a life-saving role by help babies receive the benefits of early initiation and exclusive feeding of human milk. So donor human milk, evidence-based studies showed that donor human milk reduces the sepsis, reduces necrotizing enterocolitis, it lowers severe retinopathy prematurity, and donor human milk has greater feeding tolerance, less vomiting, and less gastric stasis, and reduces the length of hospital stay in NICU, so cost saving, and a better neurodevelopmental and outcome and long-term benefits also. So timely initiation of breastfeeding is essential, and also National Health Mission promoting breastfeeding practices like infant and young child feeding practices and mother's absolute affection programs. So National Health Mission established implementing and establishing the standardized technical protocols for donor screening to dispensation of human milk. So we can use expressed mother's own milk when the baby unable to suck the breast directly, and use donor human milk for babies admitted in SNCU and NICU. Donor human milk dispensed only on prescription by the treating physician as per need, and the mother can donate milk after providing her own baby. After getting informed consent, mother can voluntarily donate the milk, and it has no monetary benefits. And after getting consent, they are donating milk. And donor human milk is not used for any other purposes apart from fulfilling the feeding requirement of sick babies, and never used for any commercial purposes. And donor human milk also feed the infants is less than 6 months in case of lactation failure and insufficient milk, adoption, illness in the mother require temporary interruption of feeding, health risk to infant from the mother milk of biological mother, death of the mother. Donor human milk cannot be used for commercial purposes, and it also intended to promote breastfeeding only. Infrastructure to establish CLMC include adequate space of 350 square meter, and mothers have adequate privacy and easy accessibility to expression area, good reception administrative area, good counseling area. Milk expression area should have adequate space for expression of milk for 6 mothers, and should be equipped with electric breast pump, deep freezer, refrigerator, and storage of raw milk. And a good milk processing area should have a swing door to reduce the risk of infection. This is the small thing, but it is very important to prevent contamination. And cleaning and autoclaving room in the CLMC, and should have refrigerator, laminar airflow, and deep freezer, and microbiological laboratory to carry out cultures to test milk for ensuring safety of processed milk to screen the donor mothers also. This is our SNCU having equipped with fully equipped and adequate infrastructure, having deep freezers, laminar airflow, a refrigerator, hot air oven, and autoclave machine. This is pasteurized, using for water shake bath for pasteurization, and with good IEC materials. And this is electric breast pump, and a team of dedicated staff is required to run a CLMC successfully. Should have a CLMC manager, lactation support staff, CLMC technician, microbiologist, hygiene helper to have a standard protocols to ensure that asepsis and neonatologists, pediatricians should to overview all the functions. Should have records like donor records, has details of medical history, birth details of newborn, any acute or chronic illnesses, any lifestyle choices like on any drugs. Antenatal records should be documented, antenatal details should be documented, and the mother should be free from HIV, hepatitis, VDRL. So these tests to be done every 6 months only if mother is willing to continue continuously donating the milk, and getting signed consent to be documented, and the volume of donation per donor to be documented. And the CLMC process has 6 basic steps. Step 1 is screening of donor mothers and the milk collection in the collecting area, and the processing of donor human milk as pre-pasteurization, storage of milk at the deep freezer, cooling and aliquoting of the milk before pasteurization, and then pasteurization, and testing of donor human milk, storage of pasteurized milk at deep freezer, and dispensation of milk as per need. The mother should not compromise donor mother should not compromise on satiety for her own baby. It is a voluntary activity. Donation should be done at health facility, not in community setting is recommended. And those mothers in NICU, mothers in postnatal ward, KMs, Gangar mother care wards, and well baby clinic, female staff of the health facility can donate the milk. Donor mother should be mother's details should be documented in the donor registration form, and the exclusion criteria include mothers of received blood transfusion within past 12 months, and recipient of organ transplant past 12 months, and having tattoos with using more than one instruments, and should not be use of nicotine, and HIV, hepatitis, active TB, leukemia, lymphoma patients should not donate milk. And temporary disqualified candidates are acute or infection or reactivation of chronic illnesses. If has cough more than 2 weeks, any fungal infection of breast, mastitis, active herpes and chickenpox infection, MMR vaccine within 1 month, varicella vaccine in last 3 months, 1 month following chickenpox, rubella infection. And we have voluntary donor. This is Amritam group. They are routinely issuing milk to our CLMC. This is one IT professional voluntarily donating milk of 7 liters recently with good family support. And milk expression using manual expression or using electric breast pump can express minimum 8 times a day. With after proper labeling can be to be kept at deep freezer. Pre-pasteurization raw milk storage at -20° at deep freezer, and raw mother's own milk utilized for feeding within 24 hours, kept in refrigerator at 2 to 4 degrees centigrade. Raw donor human milk stored for maximum 3 months, and plastic polypropylene made plastic containers to be used, and a separate compartment for preterm and term milk. Mixing of raw milk to frozen milk of the same mother is not allowed to prevent contamination. Mixing of milk of donated by the same mother of different times should not be done. And thawing before pasteurization, shift the frozen donor human milk to refrigerator overnight. And for in case of emergency, we can use warm water for thawing, and not use oven. And thawed milk should never be refrozen. And pooling and aliquoting of donor human milk done in a laminar airflow system to prevent contamination, and conical flask used, and pooling milk aliquoted into clean containers under laminar airflow. Containers have adequate space to allow expansion during freezing, and tightly sealed containers to prevent contamination. 10 ml of milk sent for microbiological culture to test bacteriological count, and throughout the procedure should maintain aseptic precautions. In the pasteurization, the aim of pasteurization is to eliminate bacteria, retains milk's beneficial component and nutritive components, and the frequency depends on milk collected, and hold it Pasteurization method is used. Low temperature, long time method is used. Heating the donor human milk at 62.5 degrees centigrade and holding this temperature for 30 minutes and reduce the temperature rapidly 25 degrees centigrade to be attained within 10 minutes and final temperature of 4 degrees centigrade prior to freeze. And post donor human milk sent for culture and store at deep freezer and dispense once culture report negative, can be used for 6 months from the date of expression, and data locker can be used to record electronic record of the heat treatment. No exchange of milk between bottles and avoid flash heating. And discard raw milk or if any growth reported, and a count of colony count of 10 to the power of 4 colony forming units per ml for staph aureus, and discard pasteurized milk contains 10 to the power of 10 colony forming units per ml to be discarded, and post pasteurized donor human milk kept at deep freezer of minus 20 degrees Celsius for 6 months. And for dispensation, oldest milk used first in, first out service. Dispense after physician prescription only. Informed consent had been from recipient parents. And thawing done before donor human milk. Transfer the donor human milk to refrigerator at 4 degrees centigrade for 24 hours and brought to room temperature before used for feeding. Once brought down to room temperature, consumed within 2 hours and maximum by 4 hours. Thawed milk never be refrigerated or frozen again. This is our beneficiary 680 grams and after 1.5 months attaining 1.2 kg, we have discharged the baby, and she's the one of the beneficiary of pasteurized donor human milk. And we have system of hazard analysis and critical control point to ensure quality assurance of the steps followed in LMC. Thank you, sir.
Thank you, madam, for many valuable information. And milk can also be donated. So for organ donation committee and donation of milk to many newborn kids can save many lives. And thank you, madam, and to Dr. Rajesh Babu, sir. So our next speaker, Dr. Jayanthan, and he is a consultant ophthalmologist from KS Eye Hospital, Erode. And welcome, Dr. Jayanthan, sir. This topic is giving vision and giving hope, part of eye donation.
Thank you, sir. Am I audible, sir? Sir, am I audible, sir?
Yes, sir.
Yes, sir. Thank you, sir. Thank you, sir. Good afternoon, everyone. So my talk will be on eye donation. So can we ever imagine a life of complete darkness? It is with this darkness, over 1.3 million people are estimated to be living in India. And there are around another 10.6 million people who are estimated to have a unilateral corneal blindness. The prevalence of corneal blindness accounts for a substantial portion of total blindness, that is around 15 to 20% of all the blindness cases. Not just this, the shocking statistics is that annually new cases of corneal blindness are estimated to be added at a rate of 20 to 30,000. And India faces a significant shortage of corneal transplant with an estimated need for over 1 lakh transplant annually, while only around 25 to 48,000 are met each year. The most common causes of corneal blindness includes injury, malnutrition, infection, chemical and thermal burns, and the birth defects. Of these, the malnutrition birth defects are very, very important because these happen at the younger age and they have to have a longer life of blindness. The eye donation is a simple and a selfless act where the cornea is donated after the death to help individuals with corneal blindness regain their sight. And eye banking is a system that facilitates this donation, storage, processing, and distribution of cornea and other ocular tissues for transplantation, research, and the education purposes. Let's see the journey that has happened so far in the eye donation and eye banking. The concept of eye donation was something not new for us, at least, It has been nicely scripted in our ancient literature. To be on the real world, in 1905, the first corneal transplantation was done by Edward Zinn. 1944, the first eye bank was conducted in New York by Townley Patton. The very next year in 1945, the first eye bank of India was established in Chennai, in Eye Infirmary, now called as the Regional Institute of Ophthalmology by Professor R.E.S. Muthaiya, who did the first corneal transplantation in 1948. In 1976, the Ministry of Health, now known as the Ministry of Health and Family Welfare, launched the National Program for Control of Blindness. In 1985, the National Eye Donation Fortnight, which is usually held between the 26th of August to 8th of September, was inaugurated in 1985 by Ministry of Health and Family Welfare. It's an annual event to create awareness on eye donation. And for the past 40 years, they have been doing it successfully with various amount of awareness being connected to the public. The umbrella organization, the Eye Bank Association of India, was set up in 1989. The Transplantation of Human Organ Act was passed by the Indian Parliament in 1994, which enables harvesting of eyes anywhere by a registered medical practitioner. Till then, it was just a policy decision, and in 2007, it was the pride of a surgeon that as a corneal surgeon, we also contributed to reducing the backlog of cornea by doing the lamellar corneal transplantation. Basically, a cornea was transplanted as a whole till 2006. In 2007, it was just a part of the cornea, that is either the anterior or the posterior cornea. Few patients who was got an anterior corneal problem underwent a DAL procedure, and who had the posterior cornea problem had a DSEC procedure. So a same cornea could be cut into two halves, where the anterior is transplanted to a person who needs only the anterior cornea, and the posterior could be transplanted to a person who needs a posterior corneal transplantation. By this way, even not increasing the retrieval, we can easily improve the utilization of the cornea for more people to get sight. In 2012, the Eye Bank Association of India partnered with US SightLife to create a network between the eye banks and the surgeon to enable adequate tissue availability, improve tissue accessibility at the national level. From 2017 onwards, the National Program for Control of Blindness was renamed as National Program for Control of Blindness and Visual Impairment, which primarily aims to reduce the prevalence of avoidable blindness to 0.25% by the year of 2025. 2018, the Indian Parliament passed an amendment to Central Motor Vehicle Act, which ensured the recording of a donor status of every license holders. This has currently been enforced in few states and has helped in harvesting of the healthy donor corneas. So looking at the eye bank infrastructure, the eye bank model in India follows a three-tier integrated system, wherein the eye donation centers forms the base of the pyramid, which harvests the corneal tissue, maintains a safe storage and short transportation. Next, the tissue reaches the eye bank, which is the core of this pyramid. Here, the tissue is being processed, evaluated, preserved, distributed, and transported to the surgeon and monitored. And these eye banks are monitored and trained by the eye bank training center, which forms the top of the pyramid. The key aspect of eye banking is that the first donor identification and consent. Every eye bank works with family of deceased donors to obtain the consent of the eye tissue donation. The corneal retrieval and processing has trained personnel who harvest corneas from deceased corners, ensuring that they are handled and stored according to the strict standards. Then comes the tissue evaluation and storage. The eye banks rigorously evaluate the donor's medical history and the tissue to ensure it is suitable for transplantation using the technique like specular microscopy to assess the endothelial cell density. Then is the distribution to the surgeons. Once evaluated and approved, the cornea are distributed to the trained corneal graft surgeon for use in transplantation procedures. Of course, the research and education are also a hallmark of the eye banking to promote further improvement in the procedure. Some of the challenges in eye banking include the socio-cultural perceptions, the tissue retrieval, supply, distribution, chain formation, the workforce which is available for the eye banking, the policy support which has to be there all the time, and maintaining the quality standard to ensure the proper transplantation is being done. Let's discuss about some of the facts about eye donation. Anyone who can donate their corneas, regardless of the age, sex, or the religious belief. Only the cornea is donated. The eyes must be removed within 4 to 6 hours of death. Every removal is a quick and a simple process, takes just 10 to 15 minutes. Eye removal does not cause any noticeable disfigurement. One donor cornea can give sight up to 2 people. Donated eyes can also be used for medical and research purposes. Eye donation is a voluntary and free of services. The identities of both the donor and recipient are always kept confidential. can pledge to donate the eyes while we are alive, and the family can only authorize the donation after your death. For harvesting of a donor cornea, informed consent from the relatives is mandatory, and that's the biggest bottleneck nowadays for retrieving the cornea. The death to enucleation time should be within 6 hours during the summer and 8 hours during the winter. No gender or age bar for donation, no religion for donation. A person himself can wish to donate, or the next of kin can decide to donate after the death of the person. A person with a diabetes, hypertension, cardiac, renal problem, anyone can actually donate, since the cornea is a non-vascularized part. People who underwent eye surgeries, including cataract, LASIK, whatever it is, using glasses can also donate corneas. It is mandatory to collect the blood sample from the disease of the subject. It is subjected to the serological testing for non-reactivity of the HIV, hepatitis B, hepatitis C, and syphilis. Absolute contraindication for tissue harvesting includes patients with active viral hepatitis, viral encephalitis, HIV infection, Creutzfeldt-Jakob disease, rabies, and any forms of leukemias. Some of the common barriers in voluntary donation includes difficulty in deciding at time of the relief. Even for the pledgers, if their next of kin is not aware of it, it is very difficult to decide at the time of grief to donate it. Lack of awareness about the donation itself is very, very big barrier. Absence of motivated to coordinate donation with an eye bank is a very difficult process. At the time of a funeral, a person who is really motivated to contact the eye bank, get the eye bank personnel to retrieve the cornea is a big barrier in the eye donation. When we actually do the awareness procedures, camps and all, we used to collect the data from people who are not interested in actually pledging their eyes. These are some of the myths which actually roams around in the society. People suffering from medical condition cannot donate. Absolutely not. Any person with any kind of medical condition actually can donate. Donation actually, unless it harms the eye bank personnel, donation from anybody is actually acceptable. Old people cannot be a donor. Theoretically, they say 65 is the maximum age for donation, but any age is actually accepted, because retrieving a eyeball is actually an act of goodwill that has been created in the society. So any age is not at all a bar. And coming to the procedure per se, as I said, like initially the penetrating keratoplasty, where the whole cornea is transplanted, we need a good tissue. But nowadays, we can use the poor tissues for actually securing the structure of the globe, like a tectonic graphs, where there is an active infection in the eye. We can use that to actually maintain the structure of the eye. So anybody can donate, and age is not at all a bar. Religion does not support the eye donation. It's a myth that no religion as such says that eye donation is not appreciated. Eye donation leads to disfigurement. Cosmetically, there is no difference between a person who has donated the eyes or not after the death. And rich and famous gets donated organs faster. Eyes are expensive. These are some of the myths that are it, but definitely it has been authorized by a registry, and eyes are not for sale. We used to do this exercise when we are promoting the Eye Donation Act. Doctors won't save their life. This has been elaborately discussed by Dr. Prabhu, so I'm skipping it off. Pledging your eyes before the death. Some of them may not be very sentimental about doing this, but it has to be done because the next of the kin may not be aware of it. The corneal transplantation is experimental, has more failure. It's an absolutely wrong procedure, and more than 90% of the corneal transplantation done at the right time with the right tissue is exactly has a 100% survival rate. Eye donation delays a funeral. No, it just takes 10 minutes, and an experience that even by a normal trained non-professional person also, it just takes 10 minutes and doesn't delay the funeral formalities. How to go about on the death of the deceased pledged person? Call the nearest eye bank or the NGO as early as possible. Keep the fan switched off. AC can be on. Keep the eyes closed. Place a wet cloth or a cotton over the closed eyes. Rise the pillow with head with the pillow. After donation, the family receives a certificate. The donor and the recipient are kept absolutely confidential. Eyes are used within 2 to 3 days of preservation in the eye banks. The recipient selected by the first come first service basis from the registry, and there is no bypassing of it. It's completely managed by the Transplantation of Human Organ Act, and eyes cannot be bought or sold in the market. So the donor identification and medical history, donor screening and serological testing are done at the eye banks. Tissue evaluation, tissue processing and preservation and distribution is the core of an eye bank. The key aspect of eye donation situation in Tamilnadu. Tamilnadu stands out as the leader in eye donation within India, accounting for 25% of the national corneal donation. And in 2023-24, the corneas collected were 9,400, which was almost double that being collected between 21 to 22. So the high donation rate and the low waiting list contributes is being attributed mainly by the policymakers, which actually supports the infrastructure and the national program of blindness control by the government, and of course by the public and NGOs, especially by IMA, all the Lions Club, which creates an active awareness program throughout the year. And of course, the eye surgeons who are committed to utilization of the cornea to the best. This is the first eye transplantation which was done in 1948. This is the one which is done recently, and this is a penetrating ketoplasty where the whole cornea is transplanted. And now with a single cornea, we can go for an anterior and a posterior corneal transplantation separately. So I'd like to thank the entire team of IMA State Board for this wonderful opportunity. Thank you.
Thank you, sir. Thank you, Dr. Jayantan, sir, from the Hospital Erode, for your valuable presentation on corneal donation and where we stand. Thank you, Dr. Jayantan, sir.
Engine speed போயிட்டாரு பயங்கரம்.
Thank you, sir.
பறந்துட்டாரு. எல்லா பாயிண்ட்ஸும் கவர் பண்ணிட்டாரு. That's very nice.
Thank you.
Thank you. We welcome our next speaker, Dr. D. Gayatri, Associate Professor, and from the Government Medical, Erode Government Medical College Hospital. The topic is organ donation and brain dead donor management and overview. Welcome, Dr. D. Gayatri, madam.
Good evening, sir. Request Nandakumar sir to share my PPT, sir. I have some difficulty in seeing the share. First of all, I want to thank
You just go on, madam. We'll because time is you just go on. We'll share the slide.
Yes, sir. Actually, I am not able to share my screen. 1 second, sir. Some difficulty.
Yeah, you start your talk, madam.
Okay, sir. Sir, actually, Dr. Prabhu Murugan, he has almost covered all of my difficult points in organ donation. Actually, Erode Medical College, we started organ donation, that is organ retrieval program in, we got the license in October 22, sir. So, but the first case was done only in June 2023. So, I remember the help I received from DD Health at the time of our first patient, sir. He was a driver of the doctor, and the patient was referred from CMCHIS Coimbatore. The patient had an injury in Erode, but he was for treatment, but there he was declared brain dead, and the patient was brought here, and the first organ donor management and the retrieval surgery was done, sir. Because you remember the doctor's son, Hitendran, he was the first person who was created so much business.
So September 26th. So organ donation. So living donor, as a living person, I can donate my blood, hair, tissue, or anything. As a deceased person, we have more liberal in donating organs. So the donation can be either organs or tissues, sir. So the organs are heart, lungs, liver, pancreas, kidneys, and intestine. The tissues are cornea, veins, tendons, heart valves, bones, skin, and blood and hair. So one organ donor can save up to 8 lives. So as a living donor, I can donate my kidney, one kidney, so that I have another kidney to save myself. And even I can donate my liver, a part of my liver, to any of my relatives, because the liver can grow in 3 months to fullest size. So how to donate? We can get a donation from the related donor or spousal donor or unrelated donor. Because of the advance in the management of organ rejection, we have high quality drugs so that we prevent rejection at any cost. So we can even get donation from unrelated donor, but it is a difficult process as it is a very legal thing. We have it is a very difficult process. So the age limit is up to 70 years we can donate. So thank you, sir. Yes, sir. So regarding the brain death certificate, it is by a team of doctors, sir. First, the doctor who is treating the person in ICU, the treating intensivist. Another is the neurosurgeon or neurophysician. Another physician, and one person for the administration side, either the RMO or the medical director or the dean or anybody can form a team. So at least 4 persons should be certifying. We do not go by one-time test, and we have to do a second test after 6 hours. Brain dead. Next slide, please, sir. So the importance of 6 hours is the patient attenders can be counseled regarding organ donation, and this is another way of ensuring that the patient is really brain dead. That is, the patient is not under the influence of any drugs or anything, so that we confirm the brain death 2 times. So what happens after the second apnea test? So after the second apnea test, the patient attenders are giving consent for organ donation. Immediately, after the second apnea test, we confirm that the patient we certify that the patient is dead by brainstem death. This cause of death is written as road traffic accident with a severe traumatic brain injury, and the patient has died by brainstem death. This death is intimated to the police people, so that the police people they start their legal procedures of investigating any death. They come for, they do the inquiry at the accident site. Then they give requisition to the forensic department for a postmortem. This is a long process, sir, which happens for more than 4 to 6 hours. By the time we arrange for organ donation. So we upload all the details to the VDL app, which is an mobile app designed for organ retrieval. This is coming under the guidance of Transtan, Transplant Authority of Tamilnadu. By their guidance, we are allocated the recipient hospitals. So these hospitals, they have a registry of their own patients, and they are given priority. and they have a waiting list number, and it is allotted only by the Transtan. So we do prepare the patient for surgery, and we prepare the theaters for organ retrieval. And once all the formalities are completed, we ship the patient to the OT for organ retrieval. After the retrieval finishes, we ask the forensic people to come inside the OT itself. Usually postmortem is done in the forensic department, but in the case of organ donors, forensic people, they come to the OT and they finish the postmortem there. So each organ has a different time frame between the recovery and transplant. The kidney has 24 to 48 hours, lungs 4 to 6 hours, heart is 4 to 6 hours, liver 12 to 16 hours, intestine 4 to 6 hours, and cornea 48 hours. Whatever may be the cold ischemia times, we want a fast procedure that to reduce this cold ischemia time. Next slide, please. So online donor pledge can be done through the Transtan website. We have to go to the Transtan website and click the donor pledge. There we have to give the Aadhaar card number, which is getting verified by the SMS to our mobile number. Then we have to enter all the personal details and emergency contact details and all over whatever our click the buttons, and then it is getting accepted, and we can download the organ donation certificate. So our Tamilnadu has come in first place for 7 times. Next slide, please. So a small note on how we manage the brain dead donor, sir. So the pathophysiology is the patient is having a severe brain injury. So they have Cushing's reflex and pontine ischemia and catecholamine storm. So a lot of catecholamines are released so that the patient can have high vascular reactivity. The thoracic sympathetic chain goes for ischemia. Regarding the lungs, only 10 to 20% lungs are eligible for harvesting. The patient can have neurogenic pulmonary edema. There can be pro-inflammatory mediators released because of the lung injury. And regarding the heart, it's a catecholamine surge, and the heart undergoes severe stress. And there is because of this stress, there is depletion of ATP. The later stages can lead to vasodilatation and shock and myocardial suppression. Next slide, please. Next slide, please. So what happens is, previous slide, sir. Sir. Yes, sir, please. So what happens when we call the brain death, there is damage to the posterior pituitary also, which leads to central diabetes insipidus, and the patient passes lots of urine for maybe around 400 ml per hour. It is very difficult for us to replace the volume. So the patient can also have sick urethra syndrome and hyperglycemia. And there is a release of thromboplastin, and the patient can go for coagulopathy and leukocytosis. So our goal is to maintain the organ perfusion and maintain the BP within normal, minimal inotropes. So usually the patient, sometimes we receive patient from outside and they are in severe shock, maybe and with noradrenaline 15 ml per hour or dopamine 15 ml per hour. So our goal is to come down on inotropes by giving adequate fluids and correcting the electrolyte abnormalities. And we have to do the optimized fluid management. And we have to improve the quality of the grafts, like the heart and kidney, they should be well perfused. So in case of hypotension, we can do ultrasonogram to find the IVC diameter for fluid resuscitation. And we can do echo to know the systolic, diastolic, and ejection fraction. And inotropic support should be titrated. And we have to send the patient samples for complete blood count, routine renal and liver and electrolytes examination. And ROTAM can be used for coagulation monitoring. And the urine output, it should be adequately match the input. So when there is 400 ml output, we cannot give it within 1 hour. So we have to start vasopressin. And we have to assess the need for transfusion. And we should also monitor the temperature. So we are having warmers to make the patient in to prevent the patient from going hypothermia. We do have hourly temperature monitoring. So these are all the things which are very, very detailed, sir. I will just explain in few words. That is, one patient is coming to the casualty with head injury. We have to check the patient and assess the brain function. So if we see that the patient is not having spontaneous breathing, we can intubate, we can adequately stabilize the patient. Then we have to check all the reflexes. So we find that the patient is having signs of brainstem death, but we should not declare immediately. We have to watch for the signs and symptoms for another 6 hours. We have to again examine the patient. So at this time only, we have to say the patient's having signs of brainstem death. So this process should not be a hurried one to avoid mistakes. And we have to do all the investigations like heart evaluation, kidney evaluation, and electrolyte balance and everything. So we need minimum 6 hours from the time of admission in the hospital where clinical examination for brainstem death is done. By the time we have to rule out all the other factors like intoxication or poisoning or hypothermia or acidosis or anything. Next slide, please, sir. And we have to make sure before testing for brain death by apnea test, we have to make sure that the patient blood gases are maintained at normal. The PaO2 is more than 60 and systolic pressure should be more than 90. Glucose levels, sodium, potassium, pH, PCO2, PaO2, everything should be maintained at the normal level. And we have to test all the reflexes of the brainstem, pupillary size and light reflex, Dahl's eye movement, corneal reflex, gag reflex, cough reflex, bilateral caloric testing and pain response, then pressure over the supraorbital ridge. Next slide, please. So how to do apnea test? So we pre-oxygenate the patient. We put the patient on 100% oxygen for 3 to 5 minutes. Then we disconnect the patient from the ventilator and we supply oxygen through a cannula, oxygen cannula at a rate of 8 to 10 liters per minute. So we supply the oxygen. The patient goes for non-ventilation. The patient the ventilation is stopped. So what happens? The carbon dioxide is built up. This increased carbon dioxide, if the patient is not brain dead, it should stimulate the patient and the patient should start breathing. But if the patient is brain dead, there will be no response. And we have to watch the patient and we have to do a basic ABG and we have to do another ABG after 10 minutes of apnea. So if the the post apnea sample shows more than PaCO2 of more than 60 millimeter of mercury, we confirm the patient is brain dead. This is the apnea. We call it apnea test positive. Next slide, please. So if first apnea test is positive, we have to wait for another 6 hours to do the second apnea test. After the second apnea test, we can declare the patient as brain dead. If the patient goes for hypotension or any arrhythmia or any hypoxia, we should not continue the apnea test and we have to abandon the test. Next slide, please. So ancillary test, when the patient is, when we cannot put the patient on apnea test, we can do the CT angiogram. So some patients will be having bilateral facial-maxillary injury, thoracic injury, cervical injury, where we cannot do the apnea test. Next slide, please. So the recommended ancillary test is CT angiogram, where we assess the blood flow all the 4 major vessels. So next slide, please. This we have already seen. Next slide, please. Next slide, yes, sir. Next slide, sir. Next, sir. So we maintain the patient in the ICU. We monitor all the parameters. We make sure that the patient is maintained on low inotropes with a good perfusion, with good urinary output, and maintain all the temperature, sugars, and everything. So actually what happens is we have a very shortage of neurophysician and neurosurgeons, and all the hospitals are not having the specialists. So what the government asks is, the following people can be empaneled through the government machinery. This neurophysician, neurosurgeon, anesthesiologist, general physician, general surgeon, pediatrician, respiratory physician, cardiologist. So any of these persons, they can form the team for certifying brain death. So nobody can say, I am not neurosurgeon, I am not. So the basics for apnea test is the patient should be maintained in a good biochemical parameters and good, not in hypoxia. Next slide. So this was in 2023, sir, where we had just performed 2 organ donation, and the next time in 2024 we had done almost 12 cases, sir, with all the help of our transplant coordinators, Transtan, our hospital staff, our colleagues, PGs, CRMIs, and we get a very good support from the Rotary and all the private organizations to go this to conduct this program in a very smooth way. Next slide, please. So this was Mrs. Kumuda, who was our the wife of our first donor, Mr. Ashok Kumar, and she has initiated. She was the strong person. She only first consented for the organ donation in our hospital, and our heartfelt thanks to her and the family. Next slide, please. And thank you very much, IMA Erode, the state president, state district president, and secretary, sir. Thank you very much.
Thank you, madam, for the wonderful presentation. And it is very useful for us and very informative.
Thank you, sir. Thank you.
Now our next speaker, Dr. Vinuj, dear consultant nephrologist and transplant physician from Central Multi-Speciality Hospital, Erode. Welcome, Dr. Vinuj.
Yes, sir. Am I audible, sir?
Yeah. His topic is transplanting hope, the evaluation of kidney transplantation. Please, Dr. Vinuj.
Yes, sir.
Your presentation.
Is my slide visible, sir?
You are visible, audible.
Yes, sir.
Yes, sir. Yes, sir.
Is it visible, sir? Yes, sir. Yes. Firstly, I'd like to thank IMA and Dr. Nandakumar and Dr. Gauri Shankar for inviting me and giving me this opportunity to present on transplanting hope and the evolution of kidney transplantation. The previous speakers had very good nuances and treatment depths of managing a DDRT and the challenges in managing a DDRT recipient and the challenges we face in counseling a patient for kidney transplantation. And this, on a lighter note, I think this topic would be what we have gone through the past and the history of kidney transplantation, and what is in the present and what we hope for in the future and what is held for us in the future. The exciting times that are awaiting us in the near future. So the overview of focus will be the prehistory of transplant, the pioneering achievements by our ancestors, and the evolving immunosuppression and the current bottlenecks that are hindering the growth of transplant, and also the disruptive technologies and other ethical considerations to be kept in mind. So the prehistory of transplants. Transplant has been there around even before the mythical periods. Like the first kidney transplant, for the first head transplant was proposed by Lord Shiva to Lord Ganesha in an accident of head injury, and which was also a part of our ancestral Hindu scripts. This is supposed to be the first head transplant that has been happened in the mythical area. And this is not only in our Hindu scriptures. The presence of multiple transplants has been also noted in the Greek scriptures and also in the Christian arena also. In Greek mythology, there's a chimera that is the derivative of the word chimerism. And chimerism is when two genetically different individuals join together. And that has been a part of Greek mythology. And then Cosmos and Damian, they have transplanted a limb that was in 1460 to 1480. That was not properly done, but it was a history. And the proper history-wise that transplant started was by Dr. Alexis Carrel. He was a plastic and a vascular surgeon. What he did was he started, due to his innovation, he started transplanting the limbs of one dog to another. There in the image, it is visible, wherein the limbs of one dog that is black has been transplanted to another white dog. This was his experimental therapy. And the other thing that he was famous for was his triangulation technique, wherein a circular vessel which was converted into a triangle, and later it was anastomosed to the other side. So still we follow his methods in transplantation. And for that matter, even the aortic patch that is taken from the donor aorta is still called the Carroll's patch. He was awarded the Nobel Prize in Physiology of Medicine in 1912. And later he deviated towards other eugenic policies for which he is not infamous for. That's why he would have been the father of kidney transplantation had he been on track towards vascular anastomosis and the development of kidney transplantation per se, had he not deviated to the other side. So the first kidney transplantation proper was done by Yuri Voronoi from Ukraine. It was a deceased donor kidney transplantation. At the time in 1933, there was no history of ABO, there was no history of CDC, or we didn't have any knowledge about the HLA typing and all. At that time, what he did was he did transplant for a deceased donor. He took the kidney from a deceased donor and he transplanted it to a woman who had supposedly mercury poisoning, and she had an AKI. But 2 days later, the graft, the patient actually succumbed to the illness, to the mercury poisoning. But he blamed himself that the surgical technique was at fault, and that was the level of understanding that we had at that time. So 1954, Joseph Murray et al. First did a kidney transplantation. And in the image is visible, the person standing in the right upper corner is Joseph Murray, for which he was awarded the Nobel Prize. And in the left lower corner, he was is the donor, and the left right lower corner is the recipient. They were identical twins. So they underwent transplant initially by having a skin graft. The skin graft was accepted, noting that there was a compatibility. So even before HLA compatibility, the skin graft was done. And that acceptance was further propelled to a kidney transplantation. So after kidney transplantation, there were the rejection rates, and the overall survival of the graft was very minimal and dismal. And the 10-year survival rate was only around 20 to 25%. And after the diagnosis of the invention of HLA, etc., then came the understanding of immunology in underlying the transplantation physiology. And the evolution of immunosuppression. The initial immunosuppression was total body irradiation, that the immune cells are going and attacking the kidney. That understanding itself is quite an intriguing part. And the image is visible that the child had a holmium radionuclide total body irradiation going on. And then came the successful skin graft acceptance for identical twins, that they share the same HLA haplotype. And then the other drugs that were used were steroids and anti-lymphocyte drugs, such as azathioprine and methotrexate. That was used. There were several side effects with this. Even cyclophosphamide was used, and those were inefficient methods also. In 1960s to 70s, saw several growth of this was the post-World War scenario, and that is when there was significant growth of science that happened. Discovery of HLA by Dosset and the complement-dependent cytotoxicity crossmatch by Paul Terasaki. And in 1970s, the wonder drug cyclosporin, which was a breakthrough and provided a more potent and a targeted immunosuppressant. In 1980s, then started the triple immunosuppression therapy. That is tacrolimus, mycophenolate mofetil, and prednisolone. This is a small schema showing the depth of the several parts of actions, the location of action of each drug that we use in kidney transplant scenarios. And then came the induction immunosuppression with anti-thymocyte globulin, wherein an immediate perioperative period to totally clear off the total immunity of the body, we use an induction immunosuppression, and that was in 1980s too. That was later found out. Now the maintenance therapy that we are using is the triple therapy, that is tacrolimus, MMF, and prednisolone. There are several novel agents that are coming up based on understanding of the molecular mechanisms of rejection and sensitization of a kidney. Based on that, the novel agents are like belatacept, sirolimus, and so this is the timeline of the transplant immunosuppression evolution. In 1954, Joseph Murray he did the first successful renal transplant in an identical twin. And now we can see that several drugs are being going on. And the final holy grail of transplantation is the acceptance of the body of a kidney without any kind of immunosuppression to the patient. That is called as tolerance. So tolerance is considered to be the holy grail of kidney transplantation, wherein another person's HLA matched or a HLA matched donor provides a kidney to the recipient, and the recipient doesn't need to take any kind of immunosuppression for the long term. And that is achieved by infusion of a donor bone marrow. For example, the mother is donating to the son. The mother's bone marrow cells is infused into the recipient after the recipient's bone marrow is temporarily suppressed by irradiation or drugs, wherein the recipient's bone marrow is homed by the donor bone marrow cells, and that doesn't recognize the donor's kidney as a foreign body, and it accepts the kidney, and it also evades the need for long-term immunosuppression in we avoid the side effects of long-term immunosuppression of tacrolimus or steroids for that matter. The patients need not be on very close monitoring and infection protocols. There has also been a significant progress in surgical techniques. Initially was from Alexis Carroll, who did a transplant. And from there too, we have moved on to minimally invasive laparoscopic donor kidney nephrectomy for hassle-free, painless, and early discharge of the kidney transplant donors. And also in advanced in robotic-assisted kidney transplantation, wherein microsurgeries and creation of a patch and the creation of grafts for kidney transplant in short arteries, etc., has been done. And optimizing ischemia times. So the preservation of the kidney, as my previous speakers spoke very clearly about the importance of ischemia times in kidney. There has been advances in optimizing the ischemia times by preservation like hypothermia and normothermic machine perfusion. So this is an image of a robotic kidney assisted transplantation. And this is hypothermic machine perfusion. For example, my previous speaker, Dr. Prabhu sir, he spoke that the transport of kidneys from one place to another will be of logistic issues. Exactly. That is circumvented with the recent advances and hypothermic machine perfusion techniques, wherein the sensor unit sends in oxygenated, pre-oxygenated normothermic or hypothermic fluid into the kidneys, and the urine is collected. And there are several advantages of doing this also. The urine that is collected is assessed for the metabolic profile, and if the kidney that is producing high metabolic profile urine is detected, and also the flow velocity within the hypothermic machine perfusion is noted, then that kidney can be the prediction of the outcome of the kidney in the post-operative period can also be made based on these techniques. So the outcomes has improved drastically from the time when Dr. Joseph Murray transplanted in 1954 to now. We have an average median survival expansion by 10 to 15 years, and the 5-year graft survival is comfortably around 85 to 75%. With evolving protocols and with evolving immunosuppression techniques, the graft survival is even expected to grow higher. So these are the other challenging scenarios that have been done. Are in our country, we are yet doing a donation after brain death, that is after brain death. In other places like Spain and Belgium, etc., there is extended criteria donors and donation after circulatory death. That is even after the patient undergoes cardiac arrest. According to Maastricht classification, we have 4 classes. The patients can donate their organs too, and that would open up a huge donor pool. And that is one emerging challenges for promoting kidney transplantation and deceased donor transplantation in our country and our state for that matter. Desensitization protocols for previously transplanted patients and equity gaps in transplantation, the racial geographic disparities, and long-term immunosuppression toxicity that can be circumvented with utilization of chimerism, etc. So the future directions in kidney transplantation are xenotransplantation, regenerative medicine, and telogenic therapies. So xenotransplantation, it has been done with, so for that instance, xenotransplantation as per our ethics and as per our ancestral, Lord Ganesha was a xenotransplant recipient on a lighter note. So the barriers to xenotransplantation was, what are all the barriers? That the pig and the human resemblance doesn't happen. One, that is the immunological and the technical barriers. The size mismatch between the pig kidney or the pig heart to the human recipient. 2, there is presence of bovine, that is porcine viruses, and presence of porcine bacteria that may be transmitted to human. COVID was for itself was for a monkey. It came from a monkey to human, and it created such a huge pandemic. So that is also a point of concern that needs to be kept in mind before jumping into xenotransplantation excitations. And the physiological barriers and the social and ethical barriers, growth of kidneys from the pig, etc. So what has been achieved so far is the pig genes that are rejecting the body, the pig genes that cause direct rejection. These have been genetically modified by CRISPR techniques, and the human genes that have been added that are essential for survival of that graft in has been added to the Yucatan pig. And Mr. Slayman was the first human to receive a pig kidney, and this was done in Massachusetts General Hospital in Boston, and it's correctly known as man's greatest hospital, MGH, for that matter. But unfortunately, Mr. Slayman succumbed to some other cardiovascular complication 2 months after his kidney transplantation. And MGH had issued a statement that it is not, the kidney was functioning till his time of death, and he had a creatinine of 0.9 at the time of his expiry. And the other probable growth in future we are seeing is 3D printing of a kidney, and also an organoid models for kidney transplantation, wherein stem cell cultures and culture of a kidney can be done in a laboratory, tailored according to the HLA of that recipient, and kidney transplantation can be done even without immunosuppression, etc. These are the exciting futures. Ethical and regulatory challenges that we face in kidney transplantation are definition of brain death and circulatory death internationally, and ownership of bioengineered organs, and the financial models for xenotransplantation. There is also a public trust and informed consent in emerging technologies. So conclusion, kidney transplantation has evolved from a mythical event to an experimental intervention by Dr. And also to a clinical routine with outstanding outcomes. So major frontiers lie in overcoming rejection, expanding the organ pool, and reducing drug toxicity through tolerance protocols and bioengineered organs. So for people who are enthusiastic to know and read more about the kidney transplantation, I think this book is an excellent narrative by Dr. Joshua Meshrik. He is a transplant surgeon himself, How Death Becomes Life. Thank you. Thank you, sir. And thank you everyone for this wonderful opportunity.